My talk is about advanced EUS imaging. And I think that, okay, if we want to talk about EUS, I think that we can start from the history of EUS, because the EUS history is a continuous development over years. So we can start from probably the dinosaur era in 1980 when the radial probe has been presented. But if we want to think about the most important development of EUS, I think that we have to think about 1990 when PENTAX has presented the first linear probe, and some pioneers like Peter, that is on my back here, has shown the possibility of this new instrument to guide a needle inside a target lesion to perform EUS-Guided FNA. And then the technology development ran very fast towards a bigger channel instrument, towards the elevator. And so in 1996, we had the first paper presenting the possibility to perform not only diagnostic EUS, but also therapeutic EUS. So nowadays, in 2015, where we are looking at EUS for two main issues. The first one is the staging of GI and lung malignancy and the diagnostic and staging of pancreatic or biliary tumors. On the other hand, we have probably the future of EUS, that is the EUS-guided, which are the EUS-guided treatments. So when I had to choose, because of the time and the referees, which of these two big issues to present, I was really doubtful. But then, can we start the video, please? Then when I have to think about guided treatments, I have to say that only two big topics are already the first choice for EUS. The first one is the treatment of the pancreatic pain with the celiac plexus neurolysis. And the second is the drainage of the fluid, pancreatic fluid collection, both with plastic or metallic stent, like in this case, and the walled-off pancreatic necrosectomy. All the other stuff, all the other guided treatment until now, and particularly if we consider the biliary drainage in case of big pancreatic head masses occluding the common bile duct with failure of the RCP, that can be easily drained by the implanting of lumen-opposing metal stent to perform colloidal duodenal, or in case of the rupture of pancreatic duct, we can use our endoscope to perform a pancreatoscopy and then pass a guide wire, and then over the guide wire we can dilate the tract, and then we can put a stent to perform the pancreatic drainage. Or as well, if we can start the video, please. If we think about the possibility to guide a local treatment like the cryothermal ablation, all this stuff and also other that are appearing on the market today are already under evaluation, are not considered good to be considered as first choice treatment until now. So my choice is to think about, to present you what we do in everyday practice and where EUS can help us in everyday practice. And if we work in an everyday practice in a GI oncological department, we think about the personalized medicine, because we know that until now, radical surgery represents the mainstay of treatment, but in 2015, other treatments are coming out, like minimally invasive endoscopic treatments, neoadjuvant treatments, adjuvant treatments, and all these regimens have shown to provide a significant survival advantage to patients if they are applied to the right patient for the right indication. So all these strategies require reliable staging procedures. And if we think about reliable staging procedures nowadays in GI oncology, EUS-FNA is the answer. And why? Because with EUS-FNA, we can clearly distinguish and depict masses, pancreatic masses not detected by other cross-sectional modalities. And in pancreatic masses, we also can perform differential diagnosis between benign and malignant lesion to tell to our surgeons which kind of intervention can be performed to these patients. And also we have the possibility to depict and perform the differential diagnosis of lymph nodes. And this is mandatory when we are considering the outcome for patients with esophageal or gastric cancer, or for patients with bile duct cancer, and with EBUS for patients with lung cancer. So at the end, EUS-FNA, which are the key points? Which are the key points for the success of the EUS-FNA? We are here in the Barcelona house, and here we are talking about team. The EUS-FNA key point is that EUS-FNA should be performed by a team. The team is composed by the endosonographer, the pathologist, and the team has instruments to perform a good work. So if we think about endosonographer, I think that we have to think about great experience endosonographer. So because we know from literature that the higher is the experience, the higher is the adequacy of our specimen, and the higher is the accuracy and the benchmark that we can obtain. And on the other hand, if the lower is decreasing our capability. And the pathologist is very important. The pathologist is a great part of this team, because we know that the pathologist, if we have a good pathologist, a very expert pathologist on site in the room, we increase significantly the yield of EUS-FNA, we increase significantly the accuracy, and we decrease significantly the number of the examination that we have to repeat because of an inadequate specimen. But the instruments are very, very important. The system are very important, because if you are a good endosonographer and you have a good pathologist, but you have bad system or bad machines, you cannot depict a lesion like this 4-millimeter lesion in the uncinate process of the pancreas, and with a very, very tiny dilation of the pancreatic duct, and you cannot imagine to biopsy this lesion, which is a carcinoid tumor of the pancreas, so-called serotoninoma. So all this team is very important, but unfortunately, until nowadays, also if you have a big team, also in high volume centers, the rate of inadequate or not diagnostic specimen is nearly from 5 to 10%. Why? Because sometimes it's very difficult to choose the target lesion. Sometimes we have false cytology because of collateral problem, and sometimes it's because it's very difficult to depict in an area of chronic pancreatitis a focal lesion to be target for malignancy. So how the technology help us to increase our adequacy? Help us because give us two main big advantages and two big instruments: elastography and contrast media, to perform a real tissue characterization and to guide our biopsy in the lesion, in the target lesion. I think that everybody is aware and knows what is elastography. Then, if not, questions during the dinner. But we can say that presenting this data, that elastography is a high sensitivity in perform a differential diagnosis between the focal pancreatic lesion, with a high specificity as well. And the contrast enhanced harmonic with Sonove has the same qualities, the same sensitivity and the same specificity to perform a differential diagnosis between focal lesion and the pancreas. And most important, if we are able to combine the results of the two methods, our results are nearly the same result that we can obtain by the FNA. So if we go, can we start the video, please? We can see that there is a very, very small area here, including the common bile duct. You see this black area. This is what we see in the B mode in a patient with all the other modalities fail to detect any kind of lesion. And you see that this black area is completely blue to elastography. So it means to be rigid. And if we look, can we start the video? If we look when we inject the Sonove, you see we can look to the injection. You see the Sonove is coming to look, and you see the pancreatic tissue taking the contrast, and you see that this lesion is hypovascular, hyperenhancing. So our idea is that this lesion is an adenocarcinoma, and the biopsy that can be obtained very precisely is confirming an adenocarcinoma. Then, in this other video, we can see another lesion. We are looking to a big lesion, a huge lesion here, very hypoechoic, very black in the pancreatic head. So everybody can say, okay, this is a tumor. For sure, it's a tumor. But if we inject Sonove in this lesion, can we start the video? Okay, not the first one. Yeah, this one, please. Oh, yeah. So you see that Sonove is coming, and you see that the lesion is iso-enhancing with the rest of the pancreas. So this is typical of a benign lesion, and so our idea is this is how we can guide the biopsy, because we can use to biopsy this lesion. Can we start the video? A big needle, because our idea is that this is a very typical benign lesion, which is so-called autoimmune pancreatitis. So we can perform histology of this lesion, confirming autoimmune pancreatitis. Then other small lesions we can depict. Can we start it? And is completely black in our B mode modality. And when we inject the Sonove, you see that the lesion is completely white. So hyperenhancing, the idea is this could be a neuroendocrine tumor. And the biopsy is confirming this is a neuroendocrine tumor. And a very small cystic lesion. This is a very, very typical in our everyday practice. But if we see the Sonove, how the Sonove is hyperenhancing the wall of this lesion, this means that the wall of this lesion is really has a lot of vessels inside, and this is a ring